Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS. I'm Dr. John Langell, President of Northeast Ohio Medical University. We're pleased to bring you VITALS in collaboration with university hospitals. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service. Today, we are honored to welcome Dr. Michael Hogue to VITALS. Dr. Hogue is the 15th Executive Vice President and Chief Executive Officer of the American Pharmacists Association. Dr. Hogue has 30 years of experience in community practice as a pharmacy owner, a staff pharmacist, and an ambulatory care provider in family and preventive medicine. He has served on the faculty at Samford University and Loma Linda University, where he also served as Dean of Pharmacy. Dr. Hogue served on the development team for the APHA Pharmacy-Based Immunization Delivery National Certificate Program for pharmacists and pharmacy technicians, the immunization education standard for U.S. pharmacy professionals. He was the first pharmacist to be appointed by the CDC to serve on its COVID-19 vaccine work group in April of 2020. Dr. Hogue was inducted into the Alabama Healthcare Hall of Fame in 2018 and Alabama Pharmacy Hall of Fame in 2024 for decades of work in improving immunization rates among residents of that state. Please welcome Dr. Hogue to VITALS.
Thanks so much for having me here today. Appreciate the invitation from Neomed to speak with you today a little bit about pharmacists and some things happening in the profession of pharmacy and impact on healthcare. I'm a pharmacist by training, even though I'm the CEO of the American Pharmacists Association. Lots of interesting components to my journey. I've owned a pharmacy in a small town, was the hometown pharmacist in Alabama for community, and I've worked in family medicine offices alongside physicians, hand in hand as an integral part of a healthcare team. So I've seen our health system from a wide range of perspectives, and that forms a lot of the basis of some of the things I'm going to talk to you about today. All right, so we'll talk about how pharmacists are really vital to the future of healthcare in America, and I hope this is exciting. Whether you're a pharmacist or a physician or nurse, thinking about different ways to work with your pharmacist will be a great thing to do. Now, I always do this in every presentation. This is the headquarters of the American Pharmacists Association in Washington, D.C. We're the only non-governmental building on the National Mall on Constitution Avenue. We're directly across the street from the Lincoln Memorial. And I always issue an invitation to audiences when I'm speaking to come and visit APHA. We offer particularly wonderful tours for healthcare professionals, and just shoot us an email and we'll be happy to welcome you in for a tour. So what we're going to do today is talk a little bit about the pharmacy profession in the U.S., and it might surprise you a little bit about where pharmacists are practicing and what they do today. But what I really want to get into in the meat of the presentation today is to talk about some megatrends that are happening in healthcare in the United States and how pharmacists can actually work together with other healthcare professionals to have a better healthcare system in the U.S., and that's something that we think is really, really important. Now, most of you, when you think of a pharmacist, you probably have come to mind the pharmacist that's behind the counter when you pick up your monthly medications or however often you go to the pharmacy. And those are community-based pharmacists. And when we use the term community-based pharmacy, we mean independently owned pharmacies, corporately owned pharmacies, big box retailers. We're talking about grocery stores that have pharmacies embedded, and even hospitals and health systems that have outpatient community-based pharmacies. That's a very broad group of people. And those clinicians are working in the setting of the community to try to help impact the healthcare in their community. Hospital and health system pharmacists represent about a quarter of all the professionals in pharmacy. Ambulatory care is pharmacists who are embedded in physician office practices, working in outpatient clinics to try to help optimize medication therapy. And of course, long-term care, managed care, academia, and industry are all big parts of it. And in addition, we have pharmacists now working in aspects of the healthcare system and roles and responsibilities we'd never imagined before. We have pharmacists who work in legal and regulatory compliance. We have pharmacists that are engaged in administrative roles in the government. We have pharmacists that work in every governmental agency. The United States Public Health Service, pharmacists are the largest classification of healthcare providers that are in the U.S. Public Health Service. So it's a very wide-ranging profession, a broadly applicable degree that has lots of versatility. Now, the total number of students that have been enrolled in pharmacy school has done exactly what it has done historically, which is up and down. We see rises and falls in the numbers of students that are enrolled in schools and colleges of pharmacy. But we had a peak that occurred back in about 2014, 2015, and we've had a decline in the total number of enrollments in pharmacy schools in the time since then. And that can be described largely due to two things. One is the decreasing size of birth cohorts in the United States. We've had fewer people coming to college because there were fewer people born, and then we've got about a 20-year time frame here where there are lower birth cohorts, and not just pharmacy, but all healthcare professionals are going to see some declines in their enrollments. We also know that the pandemic had a major effect on the number of individuals that entered pharmacy school. Think about it. During the pandemic, the only healthcare location that was often open during the pandemic was a pharmacy. Many physicians' offices were closed. Other outpatient health services were diverted to ensure acute care needs of hospitalized patients were taken care of. So pharmacists had to fill in a big gap. And that big gap fill-in resulted in a lot of burnout and a lot of pharmacists that decided it was time to retire. And so that's why we've seen some of these declines. But we're seeing some changes on the positive side now, and that's important to know. Pharmacists have had some big changes happen in the last 20 years, and I just want to take a moment to just reflect on the fact that these things are not tiny things, they're big things. I was one of the pharmacists who was involved back in 1994, 95, 96 in getting pharmacists involved in adult immunization services in this country. And I helped work with APHA to create the first national training program for pharmacists and vaccines. And we partnered with the Centers for Disease Control and Prevention. And what has happened now over the last 30 years is that pharmacy-based immunizations have become a primary public health service. In fact, it's hard to imagine not getting your flu shot or your COVID shot in a pharmacy. It's become just the routine thing that people do in America now. And pharmacists now have just become a central part, a central component of the public health infrastructure in America. And as we all know, public health has been underfunded for quite some time. In this country, we tend to hyperfund during the middle of emergencies, and then when an emergency's over, we tend to defund public health. And unfortunately, what that means is that more and more of those public health services that need to be delivered fall to the community-based healthcare providers that are remaining, and that includes pharmacists. And so that's definitely a key thing that's happened over the last 20 years, where we've recognized that pharmacists are really important for our local communities. The other thing that's important to know is that in the last 20 years, all 50 states have published and have adopted laws and regulations that allow pharmacists to actually adjust, modify, initiate therapies based on a collaborative practice agreement with a physician. So pharmacists and physicians collaborate together in all kinds of settings. For example, you could imagine that in a endocrinology office, that a pharmacist might have a target A1C working with a patient that they need to reach, and the pharmacist would then have the authority to modify the drug therapy, change the doses of insulin or oral drug therapies to try to get the patient to their target A1C. And it's a very effective way to use the medication expert on the team to get to that goal. It also happens in rural settings where the same thing happens. And then lastly is there's a lot of work that has to be done to get prescription drugs, the actual pills, in the bottle and out to the patient. Many people, when they think of pharmacists, think about the person who just puts the pills in the bottle and gets them to the patient, but that's actually not the primary thing the pharmacist does. The technological innovations that have enhanced dispensing accuracy to reduce errors and improve medication safety are there. Pharmacy technicians have advanced in their roles and responsibilities on the team, and those advances have freed up pharmacists and are intentionally freeing up pharmacists more and more often across the health system to address the needs of patients and getting effective utilization of the medicines. The simplest way that I say it is we went from the situation of pharmacists making medicines, which a few pharmacists still do that compounding function, to the situation where a pharmacist's primary role on the healthcare team now is making medicines work. And that's an exciting role for pharmacists to play, and that's what we train them to do in pharmacy schools. So what are the big trends that are happening in pharmacy and healthcare? Well, I'm just going to highlight real quickly, and I'll breeze through these slides super fast so that we have time to discuss and talk, are these mega trends in pharmacy and healthcare. First of all, specialization of pharmacists is a thing. Now, for physician colleagues, you already know that medicine is highly specialized, and everybody talks about that from the time they enter medical school. But it's taken some time for pharmacy to get there. It's taken us about 50 years for us to get there. And I'll show you some data here on a coming slide, but we've definitely seen specialization in pharmacy changing. We've also seen that in order to adapt to the demands of the healthcare system, needing pharmacists to take on advanced roles in other areas, that we're seeing many colleges and schools offer dual degree programs in things like business and public health and healthcare administration and even healthcare law. There are about 400 pharmacists nationally who hold a JD in addition to their Pharm.D, very valuable people on the healthcare team. There's also postgraduate residency training. It's about a third of the profession does that. Not absolutely essential to enter practice by any means, because we have a very strong baseline clinical degree program, but the residency training helps people specialize and get down that path. And then we also know that there are pharmacists who want to take paths in research. And so we have actually preparatory programs in the BS level so that pre-pharmacy students can get a BS in pharmaceutical sciences, particularly if they're interested in a long-term career in the industry. It's a great path to take as you're coming along. Now, I mentioned that specialization. There's about 340 or 350,000 pharmacists in the United States. And as of today, there's just over 57,000 or so certificates in the United States who hold specialization in a variety of different specialties. So these acronyms, which we love our acronyms in healthcare, but these acronyms up here are board certified. For example, emergency medicine pharmacists, certified geriatrics pharmacists, certified critical care pharmacists, oncology pharmacists, infectious disease pharmacists, nutrition pharmacists. There's just so many different specialties. Ambulatory care is one. Lots of different opportunities for pharmacists. Now, this number shows over 60,000. What does that mean? Well, believe it or not, BPS, the National Board Certification organization for pharmacists in the United States, is the only board certification arm in the world through international accreditation. So we now have pharmacists in other countries that are becoming board certified. If you want more information about that, I've provided a link so you can go check out what it means to be board certified. The next big megatrend that's happening is pharmacogenomics and healthcare technology. And I've given you some just basic information here. I'm not going to go over it, but I will tell you that, 33 years ago when I started pharmacy school, there wasn't even a word pharmacogenomics, or at least it wasn't ever mentioned in pharmacy school. This has evolved so rapidly, and it's so critical now. Pharmacogenetics testing actually helps us identify what therapies are optimal for a patient. And instead of trial and error and trying to figure things out, we can get very specific right from the beginning. If we know the specifics about our patients, we can avoid adverse events by knowing certain genetic variations that occur. We can know certainly whether people are rapid metabolizers or not. We can certainly figure out whether or not some therapies work in some patients and they don't in other patients, based upon their genetic markers. So you may not know this, but pharmacists actually have the authority and capability in many states, most states actually, to conduct pharmacogenetic testing in their pharmacies, and even to be paid for that testing in some states, like California is a good example. So being able to collaborate with physicians, especially in high-risk specialties, to get the right precision therapies to the patient is a wonderful opportunity for pharmacists, physicians to practice together. We're seeing this, of course, most extensively in oncology and psychiatry, but it's also happening in cardiology. And there's no doubt that we're going to have more of this in neurology and other specialties going forward. And there will be a time in a day where every pharmacist will be able to first look at the patient's genetic results and then determine whether therapy is correct or not. So future directions are really exciting in this area. And pharmacy students who are watching this program, I'll just tell you, you need to be hungry to learn as much as you can about pharmacogenomics, because it's going to impact your professional life in ways that you can't actually see in practice today, but in just a very short period of time, you're all going to be held accountable to ensuring outcomes based upon pharmacogenomics results. And there are even innovator companies out there, and I'm not endorsing any companies. I just want to give you an example. If you don't believe this is happening, there are companies like the one that I'm showing on the screen here that have very, very aggressive plans to help pharmacists be better at providing this information to their patients. The second big megatrend that's happening that is not anticipated to get better fast, at least, is this primary care provider shortage. Everybody's talking about it, and I'm using statistics here from the AAMC and from the American Medical Association, but the number of primary care physicians, the shortage in primary care physicians is expected to be as much as just under 90,000 by 2037. And, while there are other healthcare professionals that have obviously been training in primary care, including nurse practitioners, it's very, very difficult to imagine a scenario where we don't need the entire healthcare team to be able to take care of people. I mean, stop and think about it for just a moment. There's 340,000 pharmacists in the United States, and there's 360 million people in the United States. We don't even have enough pharmacists right now to be able to take care of our entire population. We also don't have enough primary care providers in the traditional sense of the word. So what does that mean? That means that when we look at these disparities that exist in counties across the United States, and we look at the aging workforce that's there, the retirements that of the baby boomers that practice medicine and pharmacy and nursing, it's not surprising that that means the workload for those of us who are in younger generations is going to get greater, is going to grow, it's going to be greater. That leads to burnout, and we have to think about how do we decrease duplication in our healthcare system and optimize every member of the healthcare team to be able to do what it was they were trying to do so that we can address the primary care needs of the public. And so many times we get into these turf battles in pharmacy and medicine and other things, and we've got to get beyond scope of practice turf battles. We've got to think about what does our patient need in order to be able to have access to the world's greatest healthcare system. But America has the potential to have the best healthcare system in the world. Right now, it's arguable that we do or we don't have the best healthcare system. And it's largely because we really need to get these disparities and problems and systemic barriers that exist in our system resolved so that we can have every member of the healthcare team, including pharmacists, doing what they were trained to do and practicing together. I'd be remiss if I didn't mention digital health and digital therapeutics. Incredibly exciting opportunity for physicians and pharmacists, particularly to partner together. There's so many interventions in this area with the ability to use wearable technology. That's, I think, the hot topic right now. I mean, I wear one of these Aura rings. Wearable technologies have become so critical and vital to so many people's lives. I think it's something like 60% of people now have some sort of a wearable technology that tracks some aspect of health-related information. So it's just amazing. And all of this data that's available gives us the resources. It empowers the consumer, and it gives us as healthcare providers the opportunity to do things that we'd never imagined being able to do. I've listed some definitions of some things here because as we get into technology things, we're healthcare providers. We don't always know all of the definitions of all the healthcare things, of all the technology things, because technology may or may not be our bailiwick. So just to note that there's digital technology trends, but there's mobile health applications, wearable technologies, remote monitoring platforms, and digital therapeutics. These are really critical. And again, just imagine a scenario where you have a patient that's in a very rural setting and their physician is 40, 50, 60 minutes away, but they've got a local community pharmacist. And if the physician were to prescribe a digital therapeutic or have remote monitoring platforms, how could they work together with that local community pharmacist to make sure that that patient is well cared for and gets the most optimal care? Those are the things that these kinds of technologies give us the opportunity to do. And for pharmacists specifically, it just helps us with patient engagement and patient education. We've got to think about how we integrate data. We need to have our pharmacies and our healthcare systems better integrated in terms of technology and data. Just a real quick comment here that I'll make. From a very personal experience, I have parents who are in their 80s. They live in a very, very rural county in the southern tip of Illinois. It's a 40-minute drive to their primary care physician, 60 minutes to get to their specialist cardiologist. And my dad had some health issues, and his cardiologist, I met with his cardiologist via a video visit. And I asked the cardiologist, do you have a pharmacist on your team who's helping to make sure that as you transition him to new medicines and so forth, that everything's going to go together and work, because dad's got lots of specialists? And the cardiologist chuckled and said, oh, I wish I did. But here in this part of the country, we can't get enough pharmacists to come and help us do that. We'd love to do it. Maybe you've got a local pharmacist that could help. And I said, yeah, I do have a local pharmacist can help, but my pharmacist doesn't have access to your electronic health record. And we need to fix that, because if they have to call the doctor That takes the doctor's time in giving the information the pharmacist needs to make decisions, takes the pharmacist's time. We need a seamless interchange of data between pharmacies and physicians, and we don't need these artificial barriers in place. So we've got to get these electronic health records connected with community pharmacists so that these community-based pharmacists can also help these physicians get the right outcomes and help patients get the right outcomes. There's all kinds. This industry is a $660 billion industry this year, right now. By the end of this year, $660 billion in digital health. Again, pharmacy students, if I were in your shoes studying pharmacy right now, I would learn everything I could learn about digital health and how to integrate it into patient care. Whether you're getting it all in the classroom or not, get hungry about it and go find as much information as you can. Add value to the healthcare team by understanding digital health. Well, we can't have a presentation in healthcare today without talking about artificial intelligence, at least briefly. And so this is going to be the last topic I'm going to hit on. AI is a wonderful thing. In my opinion, we should embrace it. We should not fear it. There are wonderful opportunities for AI to help us get smarter about which patients might be the best patients for us to provide interventions for, the ones that are more likely to benefit from our help. They will help us optimize our workflow. AI can help us with streamlining processes and efficiency and help us get to where we need to be. We have to take into serious considerations the ethics of use of AI, and we cannot be lazy. We've got to remember that AI is just a tool like any other tool. We still have a responsibility as healthcare professionals to ensure that the recommendations we're making to patients are fully the right recommendations and clinically sound, and not just say, oh, well, AI told me so. That's not good enough. AI is a tool that you use to help you get to the right answers. So I have moved really quickly through a lot of information. I hope it's been thought-provoking and exciting for you. I have given you now my email address and contact information, but I'd just like to tell our host I'm ready for questions if you are, and let's take a few questions from the audience.
Thank you so much, Dr. Hogue. That was so informative. And I have a million questions of my own. But hi, everybody. I'm Monica Robbins. I'm the senior health correspondent for WKYC TV. And we have several questions for you. And I have a zillion spinning around in my head. But I'm going to start with the questions that were submitted earlier. This is one that we hear quite often. How can the profession shift public perception of pharmacists from pill dispensers to healthcare providers?
Yeah, I think we need to remember what pharmacists did during the pandemic. It's not really that long ago, and I think the public recalls that during that time, we went to pharmacies for everything. If you were having issues, minor illness, and you needed assistance with treating minor illness, you came to the pharmacist and you asked questions, and the pharmacist intervened. A lot of countries around the world are actually adopting a model where pharmacists are integrated as primary care providers. And Monica, I think this is fascinating because one of the areas that's doing this that I've gotten to know really well is Nova Scotia in Canada, just up to our north. And Nova Scotia adopted a law that says that pharmacists are primary health care providers because 40% of the population in Nova Scotia did not have a primary care physician, didn't have any access to a primary care provider. So there are now 138 pharmacies throughout Nova Scotia that have been certified as primary care centers, and patients can connect with those centers, and the healthcare system has connected the electronic medical record in Nova Scotia to those pharmacies. The pharmacists can do initial assessments of the patient. They can evaluate the patient's needs and, if appropriate, treat the patient in that moment. But they also have the ability through that connected system to refer the patient to another person, another physician, or a hospital or health system to be able to get additional care that the pharmacist might not be able to provide. I think what we need to think about is, we talk a lot in social media and other places about the struggles with dispensing and workload and work life and some of these things. we need to start having conversations in the public and in social media about these incredibly exciting roles that pharmacists are taking now in the healthcare system. And we need to start telling the stories of patients whose lives have been impacted in dramatic ways by pharmacists working together in the community around the healthcare team to get these appropriate outcomes.
Are you anticipating, with all the federal cuts and the state cuts relating to Medicaid, that pharmacists are going to be relied upon much more as primary care providers, considering the shortage of primary care providers and many people losing their Medicaid coverage?
Yeah, it's definitely the case. I mean, I can just lean on my own experience from when I owned an independent pharmacy a long time ago now, but it's still very relevant, I think. I was in a very rural community in Alabama where I owned that pharmacy. It was not unusual for me on a Saturday or a Sunday to get a patient who walked in who had, maybe a cut on their foot, and they didn't know, is it infected? Is it not infected? What can I do about this? What do I need to do? I can remember back then saying, well, when was the last time you had a tetanus shot? Let's talk about that. Giving the patient their tetanus vaccination as good wound care. Looking at the wound, I was trained to know how to assess whether or not a wound looks or appears infected or is not infected. I can do minor wound care, help that patient get through the weekend, or I could have looked at that wound and said, you need to get to the ER, or you need to get to the urgent care because there's something going on here we can't take care of. I can remember patients that came in and had other issues that, required me to do a referral. I remember back, and that was in the late 90s, I can remember making a telephone call and referring a patient to a cardiologist, and the cardiology office was shocked that a pharmacist was calling to make the referral into cardiology, but that's exactly what needed to happen. Pharmacists have the right tools in the tool basket. There's no question that the system is going to need pharmacists to do this work. And we've just got to set up the back-end systems to support it. We've got to make sure that there's payment to the pharmacist for the service so that it's a covered service. We've got to make sure that the data integration is there so that the physicians can see what interventions and interactions the pharmacist has had, and we've got to have this seamless bi-directional electronic healthcare record. But I think you're right. It's going to be needed in our society.
One of the things we're hearing much about is pharmacists getting more prescription privileges and being able to prescribe medications. Do you think that needs to be expanded more from, perhaps even a federal level, or do you think it needs to be more jurisdictional statewide? How do you see it, and what do you think should happen?
Well, I mean, historically in the United States, scope of practice issues have been a state issue and a states' rights issue. And I think federal government has been pretty respectful of letting the states manage their own determinations of scope of practice. I personally believe that we ought to have standard of care regulation across the board in all 50 states for physicians, pharmacists, nurses, everyone, which basically says that these healthcare team members work together to provide optimal care of the patient, and they do so in a way that meets the standard of care for that patient. So if I have a patient in front of me, Monica, that I know their A1C is out of control, and they don't have a doctor's visit scheduled for another 3 months, and they're on insulin therapy, I should be able to work with that patient to adjust their insulin dosage to get them to their goal. I'm capable of doing it. I'm trained to do it as a pharmacist, and I should be able to help them do that. On the other side, if it's a prevention therapy and I've got a patient that walks into my pharmacy and through conversation, I determine that they're at high risk of contracting HIV, I should be able to prescribe the therapy after conducting an HIV test to determine if they're positive or negative for HIV. I should be able to then prescribe the medication to prevent HIV. You don't want to take a patient that you've determined is high risk for something and then make them jump through 3 more hoops to get back into the healthcare system to get something prescribed. You got to find your opportunity to prevent disease, prevent illness, and stop it from even happening. And I think that's where pharmacists are at. Should pharmacists be prescribing everything across the board? Well, maybe not yet, but I will tell you in Great Britain, January 1st of 2026, that's exactly what's happening in Great Britain. Every pharmacist in Great Britain is authorized to prescribe any medicine that's approved by the United Kingdom's equivalent of the FDA, as long as it's not a controlled substances. So it's an interesting thing. I'm not sure we're ready yet for that in America, but we are certainly looking at how we work collaboratively together to make sure we get good outcomes.
Pharmacy students who are watching this, what's your advice to them? Should they be prepared to, perhaps talk to their state legislatures or talk to their representatives about these issues?
Yeah, I mean, just your faculty are training you to be the very best healthcare provider on the team. You are the medication expert. You're the one that needs to take responsibility. And what I always say to pharmacy students is that you have to be confident in the fact that your role on the healthcare team is to prevent, identify, and resolve medication-related problems. You need all the tools in your tool basket to be able to do that. And, that's your role on the team. It's a fundamental role of the pharmacist. And yes, you need to make sure that if there are regulatory or legislative barriers that prevent you from fulfilling your full purpose on the healthcare team and ensuring that patients have access to your full care services, then you need to get involved and you need to try to change those laws and regulations to make sure that you have that authority to fulfill your professional purpose and to fulfill the oath that you take as a pharmacist.
You were on the front lines of vaccination as a pharmacist, and also you were the first pharmacist appointed to the CDC's COVID-19 vaccine work group. Let's start there. What lessons did you learn from that experience?
That was a whirlwind. When I look back at that now, I'm not sure how any of us got through all of the stuff that had to be done. Talk about learning as the tracks were being laid down on the train. It was an interesting time. Yeah, I was the COVID-19 vaccine work group for the CDC at that time had 52 people. I was the only pharmacist on that group, and it was an interesting time. I had to be willing to speak up and talk about what our profession was able to do in the moment, but I learned a lot about science. What I would tell all of the pharmacy students, the biggest thing I learned is that you cannot rely on what someone else tells you about science. You have to own it. You have to know the science. And, I think that is so important, especially with everything that's going on with vaccines in our world today. And it's just what a current topic, for us to talk about. We really have to take responsibility to read the studies ourselves, analyze the literature, critically evaluate what the data says, and understand science. It's just critical that we do that. And I think that's probably the most valuable skill I gained and learned and perfected, I would say, during that experience serving with the CDC.
I'm so glad you brought up that topic, because considering all the confusing messaging relating to vaccines coming out of government agencies, what can pharmacists do to help patients navigate the information for their health care at this point? You mentioned reading the studies, but now you have to take that information and explain it to, on a patient level. What do they do?
Well, it is difficult. And unfortunately, we're going to wind up with a system here over the next few weeks, I'm afraid, that's going to be very fragmented with different recommendations from different professional organizations. They're going to vary from the recommendations that were made by the CDC. And, pharmacists ultimately have to listen carefully to the concerns of the patients and listen to what the real issue is underlying their concerns. Have empathy of the current patient situation, and then use your knowledge, skills, and abilities to make recommendations firmly with the patient about what you believe they should do or what you believe their options are. And I say that because we're in such a fast-paced society. Community pharmacy is a very difficult environment to work in because the volume issues are huge, and those pharmacists can sometimes be incredibly stressed and stretched. You never want to shortchange the opportunity to address the concerns of a worried patient. When you have a patient that's in front of you that's worried and concerned about a current situation, slow down, take a minute, listen carefully to what they're saying, and don't dismiss concerns they have, but listen to what their concerns are, and then from your heart speak about what you know to be true. And I don't know if this is true, I don't know if this is true, I've heard these things, but here's what I do know to be true. And I know that, in the case of a patient, you have diabetes, and that because you have diabetes, you have a increased risk of contracting upper respiratory infections. And so my goal is to make sure you're fully protected against those infections. So I'm going to recommend that today we give you the following vaccines. And that's what I think you should do. And I think that's what you have to do. You just have to slow down, listen, show empathy, validate that, okay, I hear your concerns. I don't know if that's true or this is true, but here's what I do know is true. And you move forward. And by the way, Monica, I might just add that on pharmacists.com, which is the American Pharmacists Association's website, for our members, we have an extensive array of resources to help pharmacists be better advocates and help overcome patients' concerns related to vaccines. And so I just encourage those of the students who are listening or pharmacists who are listening who are members of APHA, we've got a lot of resources to help you with this.
It's great advice and a great resource. Since we're talking to students, given your academic leadership roles, what changes do you believe are most critical for pharmacy education programs to implement in order to be better prepared for future pharmacists for an evolving patient-centered and interprofessional healthcare landscape? What do you want to see schools putting in?
Schools really need to understand that every pharmacist, regardless of practice setting, is going to have some role to play in primary care in the future. I think our new ACPE standards 2025 actually articulate this in a way that may not be very direct. It may not just say it as explicitly as I just said it. But I think regardless of whether you're an emergency room pharmacist or you're the pharmacist that's general medicine inpatient pharmacist, or you're outpatient in a community, or you're working in a clinic, there are functions of primary care that are foundational to what a pharmacist does in ensuring that patients have access and good transitions along the healthcare system. I think schools and colleges of pharmacy need to really, really focus on what that looks like in the future and what the consumer needs pharmacists to do in the healthcare system in these days. There are always going to be opportunities for greater specialization, and those things happen after graduation. My observation is a lot of schools and colleges of pharmacy try to cram everything that you might conceive that you need to know into a curriculum, and it gets bloated and overloaded, and there's just a little too much of everything in there. And in reality, I think we could think about what is it that a student could learn as a specialist if they decide to go on and become residency trained or do some additional training after graduation? What do they really need to know in order to be able to graduate? And I'd say if we'd focus on primary care prior to graduation, a lot of those things that you're teaching them right now in oncology, for example, and psychiatry and some other things, they can get that information after graduation and become a specialist. So that's kind of my programmatic advice, I think.
What is APHA doing to address the burnout issues?
Yeah, this is a huge, huge issue. So I had just come on in my role as the CEO of APHA when we had the pharmacist walkout in Kansas City, Missouri happen. And I'm sure you all remember that from news stories that happened at the time. It was a big national news story. And so I flew to Kansas City and had a private dinner with the pharmacists who walked out of the stores. And we sat and talked about their experiences. And it was an emotional evening. And something I learned that you might not have heard on the national news stories. The pharmacists who worked in those community-based settings love community-based pharmacy. They feel that it's their professional calling to work in local communities and take care of patients in local communities. I think a lot of pharmacists think that they were stuck in community pharmacy because they couldn't get a job somewhere else, and that's not the truth. These pharmacists love community pharmacy because they feel that that's what they're supposed to do. They're supposed to be in a local community working. And so they were insulted that there were a lot of pharmacists who see them as less than someone else. And we have a professional image problem there where we have pharmacists in some cases who work in hospitals and health systems and who are highly specialized who think that a pharmacist who works for a chain is not as good of a pharmacist. And folks, I'm just here to tell you that's not true. And I learned that. So we've got to think about where are we called to serve. We are all pharmacists. Where we practice is just where we've hung our shingle. And those pharmacists have gotten burned out because of some embarrassment and image problems. But then we just have a lack of technicians. Poor pay for technicians, my goodness. So APHA has a workforce center. We are partnering with Mayo Clinic to offer a well-being index. It's an app that you can download, and you can check your own personal well-being on a monthly basis. We have tools and resources that help you personally monitor your well-being with activities and resources that you can use to try to improve your well-being. We also have a project called Power, which is the pharmacist workforce and work-life reporting system, which allows pharmacists and student pharmacists to report systems-based issues that may be negatively impacting the workplace and workforce. APHA receives those anonymously through a third-party vendor, and then we use that to meet with the employers of pharmacists to say, we've identified some systemic things that need to be fixed so that we can have a better work-life and workplace. And then APHA has also started a second victim syndrome well-being offering for pharmacists to get together in a support group with counselors to be able to, if you're dealing with the loss of a colleague due to suicide or because someone's had a major medication error, to be able to talk through that and support pharmacists in that way. This is the most important topic on APHA's agenda, is dealing with the workplace and workforce issues. We're making small incremental improvements, and we've had good collaboration and cooperation from the big pharmacy employers to try to make this better. And so I think we're making progress. It's not perfect yet, but we're moving in the right direction.
Final question, and I want to leave it on a lighter note. What is giving you hope for the future of pharmacy?
Oh, I have to tell you, I love this question because I am so hopeful. I really believe that pharmacy's brightest days are ahead of us, and I'll tell you just a quick example of what gives me incredible hope. Right after I became the APHA CEO, I was asked to help co-chair a meeting that was happening at the Hall of States, just about a block and a half away from the U.S. Capitol up on Capitol Hill. The title of this meeting was Community Pharmacists Bringing an End to the HIV Epidemic. What an exciting title, Community Pharmacists Bringing an End to the HIV Epidemic. And I thought that I would be facilitating this, in a room full of pharmacists talking about strategies for pharmacists to change the approach to HIV. And it turns out that I co-chaired this session with the Elton John AIDS Foundation and with the White House Special Counsel on Ending the HIV Epidemic. And so it was not a pharmacy-centric audience. And in fact, there were 60 people in the room, only 6 of whom were pharmacists. Everyone else in the room were patients, patient advocacy organization, physicians. It was such an encouraging thing for me in my professional career to see so many non-pharmacists advocating that we need our pharmacists to be providing total HIV care. And I realize that we have gotten to the point finally where consumers understand the value of their pharmacists and they're willing to go to Capitol Hill and advocate on our behalf. That gave me so much hope, because then I felt as though we're locking arms with our patients and we're actually seeing good things happen. So, I mean, I could give you example after example, Monica, of so many hopeful things that are happening right now. If I had it to do all over again, I'd absolutely be a pharmacist, no question about it. And I love it. It's a great profession, and I hope your students are encouraged in the same way.
Dr. Hogue, thank you so much for an enlightening conversation. We could spend hours talking about so many other topics, but I am going to hand this back to Dr. Langell.
Thank you, Dr. Hogue, and thank you to all who joined us today. Join us for next month's Vitals, when we will hear from another leader who is transforming the healthcare landscape.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.